let's go back to the clinical experience. We have two nephrologists who are clearly using these drugs. Why don't you, Dr. Coyne, Dr. Provenzano, give us some anecdotal evidence, if you will, or your personal experience using these drugs. What's the patient experience like? What's your experience like? How do you dose them? The nuts and bolts of these things.
Yeah. Well, in the open label studies in dialysis patients, we get a lot of exposure to the patients, and we understand what's happening. So there, they are literally just handed the pill while they're on dialysis and asked to swallow it. So it's pretty straightforward. The hemoglobin management is and dose adjustments are very similar to what we would normally do. Our goal is to try and keep the hemoglobin above 10, not have it get certainly above 12. And these drugs don't need very many dose adjustments. So they're pretty, I don't want to use the word benign, but they're pretty automatic drug use in the dialysis setting. In the CKD setting, the roxadustat trial was versus a placebo, so patients were taking pills at home. They were getting hemoglobins checked on a regular basis, and it becomes very obvious within a month whether they're on placebo or not. Their hemoglobin starts going up, and they achieve goal and they maintain it. So very high response rates, no notable side effects that we would attribute to the drug.
And at this point, are they being given outside of a study setting? I mean, do people come to your office and say, look, I got a great drug here?
Japan and China, but not approved.
What is your expectation then? Maybe Dr. Provenzano, is this going to be something simple to use in the office setting?
So viewing it from a clinical perspective, and we focus on value, it meets a lot of the criteria that Dan and I and Stanley focused on. And I'll just reiterate a few of those. It's administered orally instead of an injection. That will allow us, I believe, to treat many patients who needed to be treated, but for whatever reason couldn't get treatment, whether it was an additional visit or going to an infusion center. So that's a positive. It appears to be as safe as the therapy now. But again, physicians are very conservative. I view this as a positive step to a more physiologic approach to treating anemia in all of our patients. I do see that as we learn more in phase 4 and 3B and phase 4 trials, and better understand the implications of sort of the total package. Transfusion rates, which we've seen an improvement already in less rescue in the roxadustat phase 3 trials, but quality of life, just the whole package as we learn more. I do think that this will replace ESA therapy in the future.
Do you give these drugs alone, or do you mix and match? Do you give iron while you're giving these drugs?
So again, it's in the US, it's not being given. So I can tell you in Japan and in China, it is managed much like I think we would manage it here and how we manage it in the trials. Basically, it's up to the nephrologist how to manage iron. If the iron stores are high or normal, then the drug is given on its own, and you monitor the iron status. If they need iron replacement, how that's administered is up to you. So basically, that's how it's being done where it is publicly available.